This week we'll return to the concept of justice by looking closer at access to healthcare. We're going to continue our trend from previous weeks where we'll start with Beacham and Childress's remarks about access to healthcare, and then we'll move on to our two articles for this week. But before moving on, I want to talk about this concept of intersectionality because it's really common in bioethics, and it's operating within Yearby's article, but she doesn't really flesh it out. And it's also lurking in the background in the Beacham and Childress chapters as well. So I think it's important to at least let you know about it, discuss it for just a second. So the idea of intersectionality is pretty straightforward, but its consequences are pretty noteworthy. So different groups can be discriminated against, and here on the screen you see disability, age, race, gender, sexuality. These are common ways in which people can experience discrimination. However, we don't neatly belong to different groups. Instead, our identities are sort of an amalgam of different groups that we participate in. And so the idea of intersectionality is that people who belong to multiple groups that are discriminated against will have these unique experiences, usually in negative experiences, I should say, and adverse health outcomes are usually associated with these intersections of different discriminated groups. So it's important to recognize that when we are trying to address one type of discrimination, that we might actually be negligent of the experiences of people who find themselves belonging to multiple groups at the same time. So that's intersectionality in a nutshell, something that you probably want to be familiar with, leaving a bioethics course. So that's my sort of overview of it. I'll look at two facets of Beacham and Childress's discussions here. One that's going to relate to the Yearby article, and then the second one that's going to relate to our second article about right to try laws. So the first one is that if you remember Beacham and Childress's conclusion about inequalities and disparities in healthcare, they argue that if you find an inequality, that doesn't necessarily mean that it's an injustice. However, when you do see inequalities and disparities, they do require close scrutiny to make sure that their causes are not rooted in unjust reasons. So based on race, ethnic, gender, social status, disparities, and the like. So for Beacham and Childress, they want us to be on guard against discrimination. However, there's the overutilization and underutilization elements to this discussion that might lead to disparities within the access, or not access, but the usage of healthcare resources. However, if you do see disparities, it's good reason to sort of dive a little bit deeper into what's going on to ensure that there is no sort of unjust practices being perpetuated. The second part, which will apply to our second reading, they ultimately talk about how there are two moral considerations to distinguish continued access from expanded access. The first one is that the principle of non-maleficence suggests that sponsors and investigators would be causing harm to research subjects by denying them further access to a product that is helping them avoid serious health problems. This is connected to reciprocity, which we see here in the second part. So reciprocity suggests that research subjects are owed access to an apparently successful treatment at the end of their service in a clinical trial because they undertook risks to help produce knowledge about the product. So these are both about continued access. So continued access is going to be you agreed to participate in a clinical trial. Your participation in a clinical trial had led to a positive result, and once the trial ends, you get to continue the treatment because of its beneficial effects for you on the basis of this principle of reciprocity, because you undertook these risks by participating in the clinical study. You didn't know if it was going to help, if it wasn't, and also you were going into it knowing that your participation was only about collecting data. So this is continued access. Expanded access occurs when the patient is not part of a clinical trial, but they are aware of its existence and want to participate as somebody who is an outsider or something like that. So that's what we've got from Beecham and Childress. Like I said, the first part will apply to the Yearby article, and then the second part we'll return to with the right to try laws. The reason I selected Yearby's article is it gives us an opportunity to talk about the role that race might play in the healthcare field. So the basis for Yearby's conversation is the existence of these health disparities where different groups experience different health conditions, often associated with other features within their life. And so it leads to these questions about discrimination that we were just talking about previously. And just to read what we've got here. So health disparities are connected to these differences in the quality of health and health care that mirror differences in socioeconomic status, racial and ethnic background, and education level, which stem from many factors, including increased risk of underlying genetic, ethnic, or familial factors. So the motivation for this paper is that there are these health disparities that exist within the healthcare field, and they're typically tied to this concept of race, which is not neat in any stretch of the imagination. So she talks about how race is sometimes treated as a social concept, sometimes treated as a biological concept, and in neither case is it really actually possible to make generalizations about people who we assign to different groups. And instead, the sort of concept of race seems to be more of a tool to separate people into groups that are actually genetically and biologically similar in many ways. So it creates this hierarchy and sort of propels these health disparities. That's the motivation, or I guess the core of the argument that's going on in this paper. One of the examples that you come across on pages, looks like 22 to 23, is sickle cell disease. So if you're familiar with sickle cell disease, it's typically treated as like a black disease. I'm doing air quotes, you can't really see me doing them, but insofar as it's associated with people who are black. However, people of all different races, Yearby says Asians, whites, and Latinos, and places like Afghanistan, Bangladesh, Burma, Greece, Honduras, India, Indonesia, Italy, Spain, and Turkey suffer from sickle cell. Yet it's used as a way to sort of put people into a specific group. It's considered a black disease. She says here, due to the misuse of race as a biological reality, sickle cell has been deemed a black disease. This harms non-black individuals because even if they show symptoms of sickle cell, they are rarely tested or provided with appropriate care, since it would call into question their racial purity. So when we start associating different diseases or different illnesses or different treatments with different races, we actually end up perpetuating these health disparities and not looking out for the best interests of our patients. That's the underlying theme here. And she continues that additionally, even though more people suffer from sickle cell than cystic fibrosis, which is usually considered a white disease, funding for cystic fibrosis research is 3.5 times more than funding for sickle cell research. And what I think she's trying to go for here is to say, when we start identifying different diseases with different races, then it allows us, well, it doesn't allow us, it leads to the discrimination of health research based on which types of groups a disease is associated with. And a little bit further down, she talks about how once we start assigning diseases to certain races that don't necessarily exist in this biological social sense, consequently, many sickle cell patients seek care in the emergency room for acute episodes called vaso-occlusive crisis, in which an inadequate blood supply triggers excruciating pain and damages vital organs. And because these patients are black and seeking pain medication in the ER, they are often tagged as drug addicts and denied treatment, resulting in many unnecessary deaths. So again, this is reiterating or reaffirming this issue that when we start using race as an identifier for different diseases, or we don't take into consideration different factors, that we can ultimately perpetuate negative outcomes associated with these health disparities. Hence, the misuse of race as a biological reality in sickle cell disease has harmed all groups because it causes collection of information that is scientifically invalid and irrelevant, which limits testing of non-blacks for the disease, as well as blacks' access to proper treatment. Racism in medicine also results in unequal treatment for all racial groups. I think that's a really powerful conclusion to derive here, and why she's very vehemently against this use of race as a consideration in healthcare to begin with. The other thing that I wanted to mention is in the next section on page 23, she goes into this breast cancer case and this triple negative breast cancer case. And she talks about how by 1992, research showed that after controlling for socioeconomic status, the disparities between black and white women were all but eliminated. So the fact that they experience these different socioeconomic conditions can lead to these health disparities, and if we control for them, then the health disparities seem to be removed. And this is the part that I really wanted to read to you, which is that she says, in response to the triple negative breast cancer research, furthermore, these studies ignore the significance of other factors shown to increase the odds of having triple negative triple negative breast cancer, such as social ecological status, Medicaid insurance, living in the Midwest and the South, and having multiple comorbidities. There we go. None of these factors are tied to biological race, but they are tied to racism, is what she sort of concludes here. And this is intersectionality writ large, which is that if you are at the confluence of a number of different discrimination or discriminatory practices, especially if you are a black woman, they are usually the ones that bioethicists focus on, because their morbidity rates, especially in pregnancy and childbirth, are much higher. And so that's one example in which, like, here intersectionality is clearly at play, and it really leads or sort of supercharges these health disparities. It really requires us to dig into the sort of justice considerations with these different illnesses and these different experiences. Finally, I just wanted to, I think where Yiri gives us this conclusion, I think it's a very strong conclusion, which is, instead of using race, either biological or social, as a measure of health disparities, research, medical guidelines, and standards of care, it is better to use social determinants of health, including neighborhood, based on zip code, education, occupation, job, health insurance coverage, income, wealth, health behaviors, experiencing racism, gender identification, disability status, and age. One of the ones I want to sort of focus on that list of that she provides is the neighborhood based on zip code. One of the common examples in environmental ethics that we talk about is Cancer Alley. If you aren't familiar, Cancer Alley is in Louisiana. It's this corridor where cancer rates are extremely high, and typically it's a predominantly black black neighborhood. It's where all these different industries just sort of pollute and a number of things, and it has all these different hazards. And if you start to try to predict health outcomes based on zip code, you can start to see these health disparities really crop up. The same thing was actually true in Salt Lake City. So Salt Lake City is pretty high elevation, and there's quite a bit of an elevation gradient. And what you would find is that the worst health conditions and the worst health disparities were people who were at the bottom of the bowl, versus the rich people who were more up in the mountains and higher elevation. The reason for that is because all the pollution settles near the bottom. And so that's where the cheaper housing was. You could see connections with redlining in the past. And so these are all cases in which, like, based on where you live and your access to health care, the access to insurance and other different considerations, education level, they're all really good predictors of health outcomes. And race is just sort of this concept that we use as a heuristic in a lot of these situations that really has no basis in genetic fact, I guess. I don't want to necessarily go that far, because as we've talked about before, there are cases in which different genetic markers are connected with transplant organs, and there's a higher success rate with some versus others. But I think the important takeaway from this paper, and why I ultimately picked it, was this idea that when we are using race as a way to classify different groups or different diseases, we are ultimately doing a disservice and perpetuating these health disparities when there are other indicating factors that would be a better place to look first. Now let's move on to right to try laws. The thinking behind right to try laws is that, imagine you are a patient that is terminally ill and there are no treatments that are available, that are regulated or approved, yet you know, or somebody knows about a treatment that is currently being developed and it's in the clinical trial phase. Do you have a right to try that treatment because you have no other option? And our authors talk about these requirements for right to try laws. So it includes the patient has a diagnosis of a terminal disease, which in some states includes permanent coma, and no other treatment options are available. Second, the experimental product has passed phase 1 safety testing and is at least in early phase 2 safety and efficacy testing. Third, the patient's healthcare provider recommends the experimental medical product. And then fourth, the patient or a designated guardian has given informed consent to take this product. Now, there are a number of different concerns associated with right to try laws. As the authors note, right to try laws have received almost equally unanimous criticism by experts in the bioethics law, clinical, and scientific communities. So, to begin, right to try laws are associated with this expanded access. So if you remember from before, it's you are not participating within this trial. You want to participate in because you are terminally ill, and this is your only option. So expanded access programs to prevent patients from trying to access treatment on the black or gray market. So meaning that if you deny them access to this trial, will they just try to find another way of accessing the treatment? And so we want to prevent that because it can put these patients at risks. And so the authors talk about important measures for the expanded access program. I won't read all those to you, but the fear is that if patients are not included in this, then they will just try to find some alternative, more risky means of accessing the treatment. Then we also have to worry about this decision, who ultimately gets to make it, and the authors are pretty clear that it's the company that's going to ultimately dictate whether or not they want to make this treatment available to you, the company that's producing the treatment, if it's a drug or what have you. And you might say, well, who are they to serve as these gatekeepers? And in a way, their position is defensible because you don't want to just allow everybody to participate in the clinical trial because it might ultimately corrupt the data. So if you're participating in a clinical trial, this is the key, if you remember from the Beecham and Childress reading, the therapeutic misconception, right? Just because you're participating in a clinical trial doesn't mean that the whole aim of the trial is to make those patients better. It's more about testing the treatment to make sure it's safe. And that's why it's got to at least be in phase 2, so it's got to pass the first phase of safety. But here, there is this misconception that right? Just because you're going to get involved, that it's going to, that the research is necessarily geared towards helping people right now. And if the company allows everybody to participate in it that wants to, then it might corrupt their data and then prevent them from moving beyond phase 2 to get the final approval. So ultimately, it's the company that sort of decide whether or not you should get access, but obviously the healthcare provider plays a pretty central role. They have to make the recommendation, and then also the patient has to agree to it. Now, these experimental treatments are pretty costly, or at least to sort of be included in this, there's a good chance that insurance won't cover it because it's not regulated, it's not approved. And so this might lead to discrimination or disparities such that patients with financial means, who may also have more time, resources, and educational skills needed to navigate a challenging healthcare system, are more likely to have greater access to these treatments. And right to try laws present significant inconsistencies across states on what constitutes terminally ill, and these inconsistencies create both confusion and increase inequalities. So just like with the race concept, when we are trying to declare somebody as terminally ill, our definition is not going to be ironclad, and it's going to have some exceptions. And so this issue of like, does a patient qualify as somebody who is terminally ill, might change based on their geographic location, which will increase these inequalities. Additionally, the harm caused by experimental treatments, access through rights to try laws, can often exceed the potential benefit. So patients who seek palliative care like hospice care or home health care, they might lose those benefits if they decide to participate in these treatments. And that might ultimately cause them more harm, especially if the treatment is ineffective. And so thinking of the patient's best interest, sometimes it's just, I don't want to give the idea that, you know, anybody who doesn't try every avenue is giving up. That's the incorrect way to perceive these situations. But it's important to recognize that there are important sort of expectations or important goals when it comes to healthcare, and it's not. It's important to ensure that patients have access to the resources that they will need, and if their insurance ultimately decides to not cover palliative care, that can be very detrimental and adverse to their ultimate health outcomes. So that's another really key aspect to this whole right to try laws bit, is that it might jeopardize people's access to other forms of health care later on. Additionally, the authors talk about how critics have focused not only on the quantity and accuracy of the information available to terminally ill patients, but also its comprehensiveness or quality. So if a patient has to authorize this treatment and they have to give informed consent, how can we ensure that they are informed to to authorize the treatment in the first place? Because that's the whole idea. There isn't really that much information available. So that raises another issue of informed consent. Can somebody truly get there when we don't really know what's going to happen because the treatment is in such an early phase? Towards the end of this paper, the authors give us two different ethical tools, which I really like, and I just wanted to point them out. So the first one is trusted consent. They talk about how different models of consent have been proposed in both clinical and research settings to overcome the problem of lack of information. And so the main idea proposed is a model of consent based on the concept of trust, whereby consent is envisaged as a process, a bidirectional consultation between healthcare providers, researchers, and patient participants that goes beyond providing information as per the traditional form of informed consent, but that is aimed at communicating values, the values that the healthcare providers or research and their instructions, and enabling choices. So this model is in line with the idea of promoting an ethics of uncertainty based on reciprocity between patients and participants and healthcare providers and researchers, and on co-producing decision-making tailored to the patient and participant. So think about situations in which you have a primary care physician that you've known for decades, and you've built up this relationship with them, and this can be a key to getting this trusted consent where you can have these conversations about what your values are and arrive at a position that, okay, even if I have a lack of information, I can sort of place my trust in this person if they think that it's a good idea to sign up for it. The second bit is, or the second tool, I guess I should say, is ethical counseling, which I like this one. So ethical counseling is a service to ensure that decisions are informed or in line with the patient's personal philosophies, in line with both the relational view of autonomy, such that, if you remember from care ethics, when we were talking about that previously, and this idea of autonomy being something that is constructed within a network of relationships and interdependencies. So this ethical counseling is trying to tap into that, and with research conducted on patient healthcare providers' communication in end-of-life care. So it's rooted in this relational autonomy and trying to ensure that, again, we are ultimately making decisions that are consistent with the patient's interests. Also, it offers a safety measure to protect patients from paternalistic medicine, therapeutic misconception, and to empower both vulnerable and more assertive patients, because it is a patient-centered approach and aims to improve decision-making by emphasizing the communication of the relevant information in a way that is tailored and responsive to the personal philosophies of patients and needs, and can inform the decision of the patient accordingly. So think of the subjective standard when it comes to expectations of what type of information to disclose here. It takes into account also the possible cultural variations in relation to how to convey information, when and how much, and it is aimed at both patients and healthcare providers. So in the end, we get this more robust sense of informed consent by employing these ethical tools. The main takeaway here from this article, why I selected it, I think this is another issue that is quite prevalent in the bioethics field that you would encounter on a day-to-day, well, maybe not a day-to-day basis, I hope it's not a day-to-day basis, but regularly encounter, in which patients are feeling stressed or worried, and they want to find something to feel hopeful about, and they might hear about these trials and ask you about participation in them. And it's important to have these sort of tools to navigate those conversations about, well, what are your actual interests? What are your values? Are we going to make a decision that's ultimately going to compromise your health outcomes by making you more susceptible to losing access to other features of your health care, like palliative care, like hospice care, home health care, things like that. And so that's why I think this trusted consent and ethical counseling is really important from this paper. Okay, now let's sort of summarize what we've talked about here. So in the Yeary article, we talked about race, and her argument is that race is a socially constructed term that is often invoked to suggest that different practices or treatments are more appropriate for certain groups, and they create these hierarchies that supercharge these health disparities. And instead of using race, she suggests that we might be better off by evaluating disparities based on factors like neighborhood, education, occupation, income, wealth, health insurance, disability status, age, etc. Then looking at the right to try laws, which we were just talking about, the decision to allow patients to try experimental therapies is ultimately made by the manufacturers in many cases, yet a lot of different people are playing a role here. So healthcare providers making the recommendation in the first place, the patient also has to authorize and agree to the treatment. And this leads to a number of issues with informed consent. So it is a challenge for healthcare providers to obtain informed consent in a robust sense that we were trying to pursue in most other circumstances, because the experimental therapy, there's just not that much information available.